Welcome. Today we present Advanced Concepts in Pediatric TB, Infection Control, Source Case, and Contact Investigation. Today's presenter is Dr. Ana Alvarez. She is a graduate of the School of Medicine, Universidad de Panama. She did her residency training in pediatrics at Metro Health Medical Center and her fellowship in pediatric infectious diseases at Rainbow Babies and Children's Hospital, Case Western Reserve University, both in Cleveland, Ohio. Since 2005, she has been the pediatric consultant for the Southeastern National TB Center and faculty of the Comprehensive Clinical TB course, both of the SNTC. In 2013, she was appointed by the Secretary of the Health and Human Services to the Advisory Council for the Elimination of Tuberculosis. Dr. Alvarez is currently an associate professor at the University of Florida College of Medicine in Jacksonville in the Division of Pediatric Infectious Diseases and Immunology. Dr. Alvarez, I turn it over to you now.
Thank you, Karen. Let's go ahead and start. First, I want to review the objectives. So my hope is that at the end of this session, the participants will be able to compare contagiousness of children of different ages with pulmonary TB and apply these to planning investigations, discuss the importance and indications of source case investigation, plan evaluation for contacts of patients with various forms of TB disease, and discuss infection control guidelines for a child hospitalized with TB disease. I usually try to incorporate cases, so we will start with this. I want to give you these from the beginning. All of the cases that we're going to discuss today are real cases. These things really happened. Before the case, I want to review some key terms that we're going to be talking about on this session. Case is a particular patient with TB disease, and all TB cases are reportable. Contact is someone who has been exposed to tuberculosis by sharing airspace with a person that has infectious TB. This is also known as an exposed person. Index case is the first case or the first patient that comes to the attention of the medical community as an indicator of a potential public health problem. And a source case is the case or person who was the original source of the infection for secondary cases or contacts. This person, the source case, can be the index case, but it's not always the index case. So let's jump to review the case. So the index case is a 2-year-old African-American male who presented to the emergency room with 8-day history of fever and cough. He was evaluated there and diagnosed with pneumonia, and he was prescribed amoxicillin as usual. After 5 days, his fever was not getting better, so was brought back to the emergency room, and it was decided to admit him to the hospital for IV antibiotics. He was started on ceftriaxone, and he continued to have fevers, so vancomycin was added, and he continued to have fevers. His past medical history was not significant for really anything. His family and social history was significant for, he was living with the mother and 2 older siblings. He had attended a daycare center since he was 7 months. He had no history of travel or contacts with adults with HIV, IV drug users, homeless, or incarcerated individuals. On physical exam, they couldn't find anything except for a fever of 41 degrees Celsius. And this is his initial chest x-ray that was taken in the ER. So you can see that this x-ray is not normal. This is what caught the attention of the physicians and the radiologists, and this was read as a possible opacification in the right middle lobe. Was described by the radiologist as a round pneumonia, which is typically seen with pneumococcal pneumonia. So that's why he was started on IV antibiotics, thinking that this was a bacterial pneumonia. However, after 7 days of IV antibiotics, pretty broad spectrum antibiotics, he continued to have fevers, and that's when they called an infectious disease consult. When we evaluated him, we recommend to do a CAT scan to figure out what exactly was going on. The concerns at that point was if there was maybe a congenital anomaly there or a foreign body or something different than the suspicion for bacterial pneumonia. So the CT scan was performed, and I'm just showing you one part here that shows there were significant hilar lymphadenopathies on the right side, and one of the lymph nodes was so big that was compressing the right main bronchus. So based on this, we decided to evaluate him, expand the differential diagnosis. So a TSD was placed, and it was read as 10 millimeters of induration. We also recommended gastric aspirates. They were sent ×3. He was started on INH, rifampin, and pyrazinamide, and the fever resolved after 3 days of starting therapy. Yeah, he was discharged home to continue medications under DOT. His gastric aspirates finally were negative, all of them. So this is a case, a 2-year-old African-American male with a clinical case of pulmonary TB. So the question is, what would you do next? I would like for you to answer this question before we proceed. So the options are obtain a biopsy of hilar lymph nodes to confirm TB. Since the patient is responding to anti-TB medications, you need just to complete the 6 months of therapy. Plan and conduct a contact investigation, or plan and conduct a source case investigation. I will give you a few seconds to still enter your answers. I can see that most of the people are agreeing with the fourth option, which is plan and conduct a source case investigation. Emily, you can close this and we continue. And I agree with you. That would be the next thing to do. So let's talk about source case investigations. So these kind of investigations are different from contact investigations. In the source case investigation, we are looking for the person who transmitted the TB to the child or the patient. We know that TB in children less than 5 years of age indicates a recent transmission. And young children usually do not transmit TB to others. So the source case is usually an adult or an adolescent caregiver. A source case investigation should be considered for all children less than 5 years, but especially if they're less than 2 years of age that have TB, because we know that they usually, the kids under 2 years of age, when they develop TB disease, usually occur within the first 6 months of exposure, 6 months to a year. So we have a pretty good indication that they were exposed to somebody with contagious TB during that period of time. So source case investigations are important for public health and also as a diagnostic measure. So for public health, we try to identify individuals that infected the child, but that, understandable, are also transmitting TB to others. So it's an infectious person that doesn't know the diagnosis and is spreading it. But the diagnostic value of a source case investigation is that when we identify a person and it's a pretty good link to the index case or to the child, then obtaining sputum from that source case usually has a better yield than obtaining gastric aspirates from the children. So if we can isolate the organism from the source case, we can assume that the child has the same organism, and we will have susceptibilities of the organism. I usually get asked questions about source case investigations for children with latent tuberculosis infection. We know this for experience that it's not very productive and is not very cost efficient. So when deciding to do source case investigations for LTBI, you need to consider it's worth doing it. And it's only recommended for children less than 2 years of age who have LTBI, and if the data is monitored to determine the value of the investigation. So the procedures for the source case investigation are pretty similar to the standard contact investigation, and I will go through that in a few minutes. But it needs to be, the source case investigation needs to especially focus on patients or associates that have symptoms of TB disease, and should begin with the closest associates and expand only if you can find the source case in the closest contacts of that patient. So going back to our case, a source case investigation was conducted. All of the households were tested and they were negative, so the investigation was expanded to the daycare. I told you that he had been in daycare since he was 7 months old. At the daycare, we identified 3 of the staff that had a positive TST but negative chest X-ray. However, a month later, one of the workers from the daycare who had been tested initially and had a negative TST had a history of chronic cough, and then she was eventually diagnosed with pulmonary TB that was cavitary and smear positive. So this was the source case. So the question is, what do we do next? So the next step is really a contact investigation. It's important to notice the difference between source case investigation and contact investigation. And notice that for the 2-year-old that was diagnosed with pulmonary TB, we conducted a source case investigation. We did not conduct a contact investigation. However, now that we have an adult with infectious TB, we decided to conduct a contact investigation. So the strategy is a little different. Contact investigations are important because it's a prevention strategy. On average, 10 contacts are identified for each person with infectious TB in the U.S. Of the contacts, usually 20 to 30% have LTBI. So if you think about 10 contacts, you think 2 or 3 people would have LTBI, and 1 person will have TB disease. And of all the patients that develop disease, approximately half of them develop it in the first year after the exposure. Contact investigations are useful because it helps us find and treat additional TB cases, potentially interrupting future transmission of TB. And we also, it also allows us to find persons that have actually developed latent tuberculosis infection and treat them so that we avert future cases of TB. Contact investigations are particularly important in pediatrics. In the United States, we divide up how we discover the cases in pediatrics, and they are discovered either actively or passively. Actively means via contact investigations or screening of high-risk groups, and passive means that the patient develops symptoms, are evaluated for symptoms. Depending on the literature that you review and the article that you review, there are several publications on this. Up to 25 to 80% of the children with TB are identified in contact investigations. So this highlights the importance, especially for pediatrics. The contact investigations are conducted by the health department, but it's important to realize that these are very difficult and complicated activities. It requires many independent decisions and time-consuming interventions. So in deciding when to conduct a contact investigation, a lot of factors need to be taken into account. The public health officials should decide if a contact investigation is necessary based on the case, and they should be assigned, the contact should be assigned priorities, and they should be evaluated according to their priorities. So the factors that predict the transmission or likely transmission of TB, which is what the health department takes into account in deciding when to conduct a contact investigation. The factors are the anatomical site of the disease, the positivity of the sputum, radiographic findings such as cavitation, behaviors or procedures that increase aerosolization of respiratory secretions, age, HIV status, and administration of effective treatment. So the characteristics of the index case that are associated with an increased risk of transmission include pulmonary, laryngeal, or pleural TB. I want to stop here and saying that pleural TB, even though sometimes we don't see infiltrates in the lungs, the recommendation is to include it in the same category as pulmonary TB when deciding to do contact investigations or not. The other factors are sputums that are positive on AFB smear, cavitation on chest X-ray, adolescents and adult patients, and if no treatment or ineffective treatment is in place. So once the decision is made to conduct a contact investigation, the health department goes into this process of determining what is the infectious period so that they can identify which contacts they need to test. So in determining these, they take into consideration approximate date of symptoms, the results of the smears, and the extent of the disease. In general, it's recommended to start the infectious period 3 months before the diagnosis of TB. Sometimes the infectious period is started a lot earlier, and this is in cases where the patient clearly has a history of having symptoms, especially cough, for longer periods of time. So once the infectious period is decided, then there is a list of contacts that are prioritized according to certain characteristics. So the priority of the contact is decided based on the characteristic of the index or the source patient, the characteristic of the contacts that have been exposed, so including especially the age, the immune status, and other medical conditions that predispose them to develop TB disease, and also according to the type of exposure they've had. I'm not going to go in detail through this, but in this table, you see an example of how contacts are classified according to priorities. And so the high priorities and the medium priorities are the contacts that should be evaluated first. I want to bring up to your attention that patients with that are less than 5 years of age, just because they are at high risk of developing TB disease, are considered high risk and high priority. Also, patients that have medical conditions like HIV and contacts in a congregate setting. So we'll go back to our case. As I said, after the worker was identified, a contact investigation was conducted. So 52 children were identified as being exposed within the previous 3 months. They were identified and all of them were tested, had a review of systems, physical exam, TST, and a chest X-ray. 24 children had a positive TST, and of these, 5 additional children were diagnosed with pulmonary TB, and one patient had pulmonary and meningitis. 18 children had latent tuberculosis infection. 28 children had negative TST and X-rays, and they were started on window prophylaxis if they were less than 5 years of age. All of them were retested after 10 weeks of the exposure, and in the retest, 2 more children were detected as positive. So this case really highlights the importance of daycare settings, and they are definitely a high priority for contact investigation. And this is because the children that attend daycares are usually less than 5 years of age, which means that they are at higher risk of developing TB disease and more severe disease. They have a prolonged exposure since most of them spend the whole day in the daycare center. And because they're infants and toddlers, they are usually a close contact. Depending on the size of the daycare center, there could be crowding and poor ventilation. And all of these create the perfect environment for the perfect storm. So if you compare the slide that I showed you before, the averages for a regular general population contact investigation, as I said, usually 10 contacts are identified. We identified 52 exposed children. Usually 2 to 3 out of 10 or 20 to 30% of the contacts had LTBI. We had almost 40% of the children had LTBI. But more importantly, in general, usually you find 1% of the contacts have TB disease, and half of them develop it during the first half of the first year after the exposure. We actually had 12% of the children that were exposed developed TB disease, and all of them developed it within the first 6 months after exposure. So I just want to make sure that and highlight the importance of doing a contact investigation when there is TB in a daycare setting. So once we decide who needs to be evaluated, then the next thing to discuss is what evaluations we do on the contact. So unless they have a history of having a previous positive TST of IGRA or have had TB and treated, then you should do this, a TST or an IGRA. If TST is used, the cutoff that is used to call a positive is 5 millimeters or more in any contact. If the TST or the IGRA is negative, then we should repeat the test in 8 to 10 weeks. This is what we call the window period, and this 8 to 10 weeks after the last exposure, not after the last test, but after the last exposure. If the second test is positive after the initial negative, then the contact is classified as recently infected. And this means that this person is at higher risk for developing TB disease. All of the contacts that have positive TST or IGRAs, or if they report any symptoms consistent with TB, even if they do not have a positive IGRA, need to have a complete history and physical, a chest x-ray, and other tests as indicated depending on what symptoms they have. I do want to mention, say, an explanation about the window period prophylaxis. And this is decided, this is not done routinely on all of the contacts, but it is decided taking into consideration the frequency, duration, and intensity of the exposure and the risk factors for TB disease among the contacts, especially the age and the medical conditions that predispose them to develop TB disease if they get infected. So based on this, the way we manage contacts that are younger than 5 years of age is the following. It's a little bit different than contacts that are older or have no risk factors. So all of the, when children less than 5 years are identified as contacts, they should all have an evaluation that should include a TST, a chest x-ray, and review of symptoms and physical exam. All of them, all of that evaluation. If all of that is negative, then we start them on window prophylaxis, which is really primary prophylaxis. They are started on INH, and then they have a repeat TST placed 8 to 10 weeks after their last exposure. If the repeat TST is negative, you can stop the INH. And I have to say also if they didn't develop any symptoms. If the repeat TST is positive and they have not developed any symptoms, then they continue the INH to complete 9 months as treatment for latent tuberculosis infection. If at any time during the window period the patient develops symptoms, fevers, cough, or anything that is suspicious for TB, they should be reevaluated and investigated again for possibility of active disease. Prophylactic treatment is a little bit different, and this is obviously prophylactic because you have to exclude that TB disease. But this is recommended for persons that have a high risk and on which you cannot really exclude LTBI because it's hard to interpret the IGRA or the TST. So that includes persons with HIV, persons taking immunosuppressive therapy for organ transplants, and persons taking anti-tumor necrosis factor alpha agents. Because in these patients, the interpretation of the TST or the IGRAs is questionable because they may be allergic and not able to respond. We feel that, and they have a very high risk of developing TB disease, then these contacts should actually receive 9 months of INH, assuming that they did get the infection. So in these patients, we do the TST and the IGRAs, and if they are positive, then we know for sure. But even if their TST and IGRAs and their chest x-rays are negative, they are started on INH and treated for 9 months. So they don't have a repeat TST done. So I call this the story that never ends. So going back to our case, 7 months later, you can imagine how active we were during those 7 months. But when we were thinking that we were out of the woods, a high school student with no risk factors was diagnosed with pulmonary TB. He had cavitary and smear-positive pulmonary TB. So the question is, where did he get it from, and how is this related to the daycare center? Well, he was the grandson of a friend of the worker, and he had occasional contacts with her, with the source case, before her diagnosis. However, he had not been identified as a contact in the previous investigation. And we know that he got it from her because we were able to isolate MTV, and it was genotypically identical to the source case. So this is an example of what happens when we miss somebody during the contact investigation, especially persons that are at high risk like adolescents are. So because he had cavitary and smear-positive TB, and he was a teenager, the contact investigation was conducted at the high school. So initially, there were 197 contacts identified. This is based on students that share the same classroom and 4 teammates and bus riders with this teenager. In the first round of testing, 8% of the students were positive by TST, and when they had the repeat test done 8 to 10 weeks later, we found another 18 students with LTBI, so that's 17%. And because this is a large number of conversions on the second round of TST, we expanded the contact investigation, and an additional 206 contacts were investigated. And the ratio of TST at that point was 4%. So we identified another 8 patients. And we stopped there. All of the contacts that were identified as converters, TST, had negative x-rays, and basically none of them had TB disease. So when do we determine to expand the contact investigation? We basically need to take into consideration the extent of the recent transmission. So if there is an unexpected low rate of infection or TB disease in the high priority contacts, if there's evidence of a second generation transmission, if there is TB disease in any of the contacts that are not high risk or medium priority, if there's infection of any contacts that are less than 5 years of age, and if there is a high degree of conversion in the repeat testing, in the repeat TST or IGRA testing. And the story never ends. It keeps going and going and going. So 1 month later, a 7-month-old male, cousin of the high school student, was diagnosed with pulmonary TB. This is true. All of the stories are true. I'm not making this up. This patient, this 7-month-old baby, had been identified as a contact and had been evaluated by his primary care provider. He had a TST that was negative, and he was asymptomatic, so no further intervention was done. No chest X-ray was done, and basically they said he was negative, and that's it. A month later, he presented with fever, wheezing, and a productive cough. And his chest X-ray showed a right hilar adenopathy and right upper lobe infiltrate. We did gastric aspirates on him, and they were positive by smear and by culture. And the story keeps going and going and going and going. This baby had attended a small child care center. I'm truly not making this up. Because the baby had extensive disease, had significant cough, and his smears was positive on the gastric aspirate. And frankly, because there was a lot, by this time there was a lot of anxiety among the public and the community because of the previous daycare and then the teenager and the high school, we decided to conduct a contact investigation in the child care center. Identified 8 workers and 4 workers and 8 infants. and all of their evaluations were negative. So there was no transmission of TB in the second daycare center. So why not doing contact investigations in young children? And this is why I put that as an example. We just need to go back to remember the transmission, how the transmission occurs. We need to remember that it's an airborne infection. So in order to acquire the infection, the contacts would have to inhale the droplet nuclei produced by an adult or an adolescent that have pulmonary or laryngeal TB. And the infectiousness correlates with the number of organisms expelled. So we don't conduct usually contact investigations in young children because they have very low yield. Most children with TB are not contagious. I'm talking about young children. Because compared to adults, they are less likely to have a productive cough. They are less likely to generate force to aerosolize the organisms. And they usually do not have large numbers of organisms. The other thing to remember is that children that have extrapulmonary TB are not infectious unless the disease is in the larynx or they have open abscesses or lesions. So when do you consider a contact investigation in children? Even though the transmission from children is rare, it can occur in certain circumstances, and that include when the children have what we call adult-type disease. That means that they have extensive upper lobe disease and cavitations. Also, when there are procedures that create aerosolization of the bacilli. So children that have to undergo bronchoscopy or induce sputums without the necessary precautions should undergo contact investigation. So let's say a child is admitted and get a bronchoscopy and there's no suspicion for TB, so no precautions are taken at the time of a bronchoscopy, then a contact investigation should occur there to see if there was any transmission because there were not enough isolation precautions. And I want to clarify in here that gastric aspirates are not associated with transmission, so they're not considered high-risk procedures for aerosolization of the bacilli. So let's talk a little bit about infection control. I am not going to discuss all of the recommendations because there's too many and there's a whole lecture, there could be a whole lecture on this. The guidelines are published by the CDC about how to prevent transmission in a healthcare setting. So I'm not going to talk about that. I'm just going to touch quickly on the general principles of this. So the fundamentals of infection control include administrative controls, environmental controls, and respiratory protection. Fundamental controls of infection include administrative controls. So these are things that we do to reduce the risk of exposure via an effective infection control program. So the infection control program is supposed to assign the responsibility of the facility, conduct annual risk assessment of the facility, institute a plan, an infection control plan to identify TB suspects, isolate them, evaluate them, and treat them, ensure that that facility has recommended laboratory services, and that the healthcare workers and the patients and visitors are educated, trained, and counseled about TB. The environmental controls prevent the spread and reduce the concentration of the droplet nuclei. And these include primary controls and secondary controls. So primary controls is usually the ventilation issues and the use of A2 rooms. Secondary controls include HEPA filters and ultraviolet germicidal irradiation. So characteristics of A2 rooms are single patient rooms with private bathrooms, negative pressure relative to the hallway, all the air sent outdoors or HEPA filters, and the exchanges are 6 or more air changes per hour. And the visitors to the patients in those rooms should wear N95 respirators. The respiratory protection controls further decrease the risk of exposure in special areas or circumstances. So this consists of using personal protective equipment in areas with increased risk of exposure. So this equipment should be used by persons entering the rooms of patients that have suspected of confirmed TB, and wherever there are procedures that can produce cough or aerosolize the organism. The protective equipment includes N95 respirators, and these need to be fitted because there are different sizes and features, and so each person that works in a healthcare center that has any risk of TB should have a feeding process for the N95 respirators. These are worn by the healthcare workers, not by the patients. The patients wear a surgical mask, and the purpose of this is to stop the droplet nuclei from being spread, exhaled by the patient. This should not be worn by the healthcare worker. So in deciding infection control in a hospital, you need to take into account risk factors for infectiousness. So the presence of a productive cough, the presence of cavitation or extensive upper lobe disease, positive AFB in the sputum, or involvement of the larynx, failure to cover the mouth or nose with cough, and the presence of procedures that generate aerosols that could contain the bacilli. So based on those risks, adult patients that are admitted to the hospital with TB or suspected TB should have airborne infection isolation. That means that they should be placed in negative pressure rooms, so what we call the A2 rooms, and they should wear, all of the healthcare workers and the visitors entering the room should wear N95 masks. And the isolation is discontinued when if it's a suspect case, when another diagnosis is found that can explain the symptoms and excludes TB, or if 3 negative AFB sputum smears are negative. If there is confirmed TB, the isolation can be discontinued when there is effective therapy and clinical improvement and 3 negative smears. The isolation of patients that are children is a little bit different. And this, I want to make a point, stop here a little bit to explain this a little bit more. So children, like I said before, with TB, if they're less than 10 years of age, are rarely infectious. Nosocomial transmission in pediatric care settings is extremely rare. However, adults that are accompanying the children into the hospital may be the source case, and they could potentially be infectious. So the emphasis on infection control when children less than 10 are admitted to the hospital should be in the adults, not as much in the kids. So the general recommendation is to isolate the children until their infectiousness is excluded, but also until the adults that are accompanying the patient have been evaluated and infectiousness is excluded in them. So chest x-ray is a critical component of the evaluation. And until that evaluation is complete, we should limit the visitation, or visitors should wear masks, not only in the room, they shouldn't actually, they don't need to wear masks in the room if they are parents or people that have already been living with the patient, but they should wear masks in the common areas of the hospital until they are cleared that they are not infectious. And this is not something that is done routinely. Some hospitals do. Whenever there was a survey to see how many of the children's hospitals do these, this survey is old, but at that time there were only 42% of the hospitals were actually evaluating adults accompanying children with suspected TB that were admitted to the hospital. In 2002, Dr. Stark actually and his group published a study that they did at the Children's Hospital in Texas, where they actually screened adults that were caretakers of children admitted with suspicion of TB. And they actually, the adults had to be screened prior to the admission. The chest X-ray was part of the screening. And if there was any delay in evaluating the adults, then they put the kids in contact airborne isolation. But if the children were young and did not have any of the high-risk categories like cavitations or laryngeal TB, or any procedures that could aerosolize the bacilli, they were actually not isolated. As long as the kid was considered not infectious or contagious and the adults accompanying the kid were not contagious, they actually did not have to do airborne isolation on those, or they decided not to do airborne isolation. So when they look at their study period, there were 59 children that were identified as admitted with suspected TB, and once they applied their criteria, only 8 children required isolation. And they screened 105 adults and actually found 15% of them had abnormal chest X-rays compatible with TB, and they did not know that they had it. So this study really brings up and highlights the importance of actually having a process to screen adults that are accompanying children when they get admitted in our hospitals for suspicion of TB. And just to highlight the fact that children rarely transmit disease. In this particular study, they also looked at if there was a conversion rate that changed in regards to before the study period and during their study period to see if there was more healthcare workers that converted TST, and their rate did not change. They even go ahead and try to see if any of the healthcare workers have converted and TST. They evaluated if any of them had been in touch or contact of these kids that were admitted, and none of them had. All of the healthcare workers that had positive TST did not have contact with these particular children. So in their study period, which took several years, they did not find any conversion associated with a pediatric case. So again, it's just to highlight the importance of making emphasis more in the adults than in the actual kids. The next session that I want to review is something that I get a lot of questions about, and it is usually when there is babies, a newborn, that have mothers that have some TB of different stages. So if the mother has LTBI, meaning the mother has a reactive TST or IGRA and a normal X-ray and is asymptomatic, so no cough or fever or any symptoms suggestive of TB, then no separation is necessary. The mother should be treated for LTBI, so the mother should be referred to the health department to be treated for LTBI after the initial postpartum period. The newborns need no further evaluation, but it's recommended that other household members should be evaluated for TB infection or disease. However, we should not hold the babies from discharge waiting for the household evaluations, but it should be strongly recommended. And these mothers can breastfeed their infants without any limitations. Next case scenario is if the mother has suspected TB. So this is a mother that has clinical signs and symptoms or an abnormal chest X-ray consistent with TB disease. So in this case, the mother should be evaluated as soon as possible, and we recommend to separate the mother from the infant until the evaluation is complete. If TB is suspected or confirmed, we recommend to separate them until the mother is receiving adequate therapy and she wears a mask and understands and is willing to follow infection control measures. So if the mother is let's say it's suspected to have or confirmed to have TB, she needs to be on treatment, wears a mask, and understands the infection control measures, and at that point you can reunite them. The mother can breastfeed the infant after 2 weeks of adequate treatment, and if she's then at that point considered not contagious. If the mother has TB disease, then we need to evaluate the infant, the baby, for congenital TB. And that includes chest x-ray, TST. Actually, we recommend to do TST on the babies even if they're newborn. This can be done, it's hard to interpret, so you can interpret a positive, but you cannot interpret a negative. They have chest x-ray, sometimes they have evaluation, LP and all that. In general, if the congenital TB is excluded, then we begin INH on the baby, and then repeat the TST when the baby is 3 to 4 months old. If the repeat TST is negative, we can discontinue the INH. If the TST is positive, we reevaluate for TB disease, and if there is no disease, then we complete 9 months of INH therapy as LTBI. Once the baby is evaluated and started on INH, separation is no longer necessary unless there is a suspicion for MDR-TB. So if the mother has disease and there is a suspicion for MDR-TB or proven MDR-TB, so you need to basically, once the mother has diagnosed of TB disease, the diagnosis of TB disease, then the next question is, could this be MDR-TB? And of course, for that, you have to remember the risk factors for MDR-TB. They're foreign-born, coming from countries where MDR is more prevalent than in the United States. If there is a history of previous treatment for TB and now has active disease, those are things that you need to consider. And if there is any suspicion that it could be MDR, then we recommend to separate the mother and the infant until the mother is considered no longer contagious. If they cannot be separated, so they have to be together for social reasons, there's nobody to keep the babies, those kind of things, then a strong consideration should be given to give BCG vaccination for the infant if there's no risk for HIV, and as I said, if the separation is not possible. This is one of the few indications for BCG vaccine in the United States. Now, if the mother has an abnormal chest x-ray, but on evaluation has no evidence of TB disease, then separation is not necessary. The mother should still receive treatment for LTBI, and the recommendation should be to investigate the household, but the babies don't need any further evaluation. So prevention of transmission in the community. In childcare, as we said, children that attend daycare are usually not contagious, even if they have TB, so they can continue attending. But it's important to identify a source case, because then if the source case is a worker from the daycare center, other children need to be evaluated. And remember that child with TB is not contagious unless they have adult-type disease. In the school setting, it's a little bit different. The children that are diagnosed with TB can attend school if they are receiving appropriate therapy. And if they have adult-type disease, then they need to be proven not contagious, so have adequate treatment for at least 2 weeks and have 3 negative smears. Any children that have adult-type disease that have been attended school, then a contact investigation should be done in the school setting. So just to finish, we want to summarize the take-home messages. So the diagnosis of TB in a child is a sentinel event representing recent transmission of TB in the community. A source case investigation should be considered when a young child is diagnosed with TB. We start with the household, but it can be expanded to non-family caregivers, so like grandparents or other nannies or daycares. Contact investigations are an essential component of TB prevention. Daycares represent the high priority for contact investigation. Young children are rarely contagious, but the source case is, so that again the importance of source case identification and the importance of using window prophylaxis in young children. I list here the references, the main references that I use, and you will have it in your handout. And now we'll open it, the panel for questions. Thank you.
Well, hello. This is Connie Haley. Can you hear me?
Yes.
Anna, thank you so much for that wonderful, wonderful discussion. As always, it was very clear and had so many good points, answered some questions that I get a lot when I take calls from the community providers as well as the health department. If you're ready, I'd like to ask you some questions that have been posed through our question line.
Sure.
One of them is going back more specifically to your patient that you described during the presentation. And the question was asking about the high school contacts. How many of those 48 high school contacts completed LTBI treatment? Do you know that information?
I don't know the exact number, but I know that most of them did, because I was involved in that investigation, and we followed them pretty closely, and so most of them did. I can't guarantee that all of them did, but it was a pretty high rate of completion.
Maybe just a quick follow-up to that, to talk about a little bit about ways that you might help improve treatment completion among high school students who are sometimes difficult to get a hold of and are busy. Could you just talk briefly about how to facilitate completion in the pediatric setting? In the context
yes. We are actually right now in Jacksonville going through this because we have another. This case that I'm describing here was many years ago, but this year we had last year, we had a case of pretty contagious TB in a high school, and we're still in the process of evaluating all the students, and many of them also have LTBI. So what we decided to do this time around, which is different than what we did several years ago, is actually treat them, instead of doing the INH for 9 months, we decided to do rifampin for 4 months. And that's because, shorter duration, more likely for them to complete. We see them every month. We see them in the clinic every month, and try to assure that they take the medication. And so we're still in that process, so I can't tell you the success rate of that, but at least we feel like we have a better control over that, making it shorter.
Yes, thank you. There were a few more questions regarding a similar topic. Regarding the contacts that are less than 5 years old, someone has asked if you repeat the skin test and it's positive, but the patient is asymptomatic, do you then recommend a chest X-ray?
No. We basically, if they started treatment, the prophylaxis, the window prophylaxis, and they remain asymptomatic, if they convert, we don't repeat the X-ray or do anything else, just continue the therapy for basically to complete 9 months. So only if they become symptomatic. Or, for example, in one particular case, it was a kid that was identified kind of late. So we had a little bit of doubt if we had started the window prophylaxis early enough. So that kid actually ended up getting a repeat chest X-ray, and it was negative. But we were just not sure if we had started the window prophylaxis early enough. So one point in here to remember is that when these kids are identified, they need to be evaluated soon. And soon we're talking about like the same week or so. Because we also have another case where there was a delay in the evaluation, and by the time we saw the kid, he developed miliary TB. And we knew that it was a contact. It was just there was a delay in the evaluation. So when these kids are less than 5 years are identified as contact, they need to be evaluated promptly, like within that same week.
Great. Okay, another question that we've received. In a situation, a daycare with so many young children, they have a number of initial positive tests. Do you ever consider putting all the children on window prophylaxis, regardless of the age, even children who might be above the age of 5?
No, I mean we did put all of the children less than 5 on the prophylaxis, and most of them in the daycare were young. There were I'm thinking maybe 2 or 3 kids that were a little bit older and they were not in the daycare the whole time. They were just going there after school, and so their time in the daycare was less, and they were a little older. But we did do TSTs on them and repeat the TSTs, but because they were older, we did not put them on window prophylaxis. And none of them developed TB disease.
So you really took it case by case, even though there was a high, patient by patient, even though there's a high rate of transmission in that setting.
Right.
Great. Okay, another question really goes respect towards the hospital infection control topic, and that is, what is the procedure of giving visitors an N95 mask without prior evaluation and fit testing? So the practical aspect of how that's handled.
Yeah, well, that depends on the hospital. Actually, is each hospital has their own policies, procedures for infection control. In the study that I described that they did it in Texas, in the Children's Hospital in Texas, the infection control program actually paid for the chest X-rays of all of the adults. And these X-rays were done at any time. Some of them were done at the health department, but some of them were done actually in the hospital, and some of them were actually read like overnight and stuff, because they wanted to, rule out disease pretty early. So they were kind of pretty aggressive on that. But I'm sure that not all hospitals are willing to pay for X-rays for all the adults. So what we do here, I tell you, what we do here is we ask signs, symptoms of on the parent or any adult accompanying the kids, and ask them if they have been tested for TB before, or any risk factors for TB, that kind of thing, and we ask them to go to the health department the following day and be evaluated there. We don't evaluate them in the hospital. But if there's anybody that has any potential symptom related to TB, we ask them either not to come to the hospital, or we do ask them to wear a mask in between, like from the entrance to the room. Once they're in the room with the kids, they don't need to wear a mask, because of course they've been living together, so there's no point in isolating them then. But as I said, sometimes that is tricky, and that's why I wanted to highlight that, because I think that more children's hospitals need to be aware of that and kind of try to include some of these recommendations into their policies.
Anna, I have a couple more questions.
Okay.
One of these questions is talking about, if you have a mother who has confirmed tuberculosis and placed on standard 4-drug therapy with rifampin, INH, pyrazinamide, and methimazole, the question is actually, is the rifampin safe in breastfeeding? But perhaps you could go ahead and talk about the safety of all 4 medications in breastfeeding, and then also whether or not the baby would require any kind of supplementation with vitamin B6 or a polyvisal type thing.
Yeah, that's a very good question. We get asked that too. So in general, the drugs are, some of the drugs are secreted in the breast milk, but the concentration of the drugs in the breast milk is very, very low. So it's not considered a contraindication to breastfeeding, and it's not considered to be in a concentration that could potentially be toxic to the babies. So it's not a contraindication. So the mom can be on the 4 drugs, and she can still breastfeed. And because the concentration in the breast milk is so low, nobody should feel that the baby is getting medicine through the breast milk, and that will protect them, because it's too low to be protective for the baby. So, for example, these babies that go home with the moms that are on TB treatment are started on INH on their own. So besides what they get in the breast milk, they actually are started on their own dose of INH. And these babies, we do recommend to do vitamin B6 on those babies too, the ones that are on INH.
Could you tell us what that dose would be for the vitamin B6? Is it based on weight? Is there enough in a standard vitamin?
It is based on weight, but I don't have the actual dose handy. I usually have to look it up.
Okay. We can maybe send that information out later.
Yes.
Another question, someone was asking about if rifampin therapy is used in young children. The question is asking, is the rifampin therapy 6 months instead of 4 when you're talking about treatment of LTBI? And what would be the age cutoff for using the 6 months over the 4 months? At what point could a child be able to take the standard 4 months of rifampin monotherapy for LTBI?
Yeah, that's a good question also. All of the questions are good. Yeah, we use basically puberty as instead of age. So basically, post-pubertal adolescents, we use the 4 months, and if they're pre-pubertal, we do 6 months of the rifampin.
Great. There was a question about BCG in the newborn, and since that's not used in our country for most situations, it's something I think many of us would like more information on. Someone was actually asking about the physiology and pharmacokinetics. Not sure it's fair to ask you that question. Answer it if you can, but maybe you could talk a little bit about the practical aspects of BCG in this situation. If you have a child with exposed to MDR TB and there's not an appropriate LTBI prophylaxis you can give, how hard is it to get it in a typical hospital setting? How old should the child be to get it? Are there any other details like that you could talk about how that would work?
Yeah, I don't know all the pharmacokinetics, but BCG is given in all of in the countries with high prevalence of TB, is given at birth. So obviously they can get it at any time. So that's not an issue. That's approved at birth, basically. And how easy it is to get it, I don't know personally, because to tell you the truth, after being here for so many years and doing TV for a long time, I've never had to use it. As a matter of fact, the only time I had to separate a mother from the baby was because there was a high index of suspicion for MDR, but we were able to find a place for the baby with another family member that was leaving it separate, and we're keeping the mom separated until she was considered not contagious. So we did not have to give BCG. So basically, you only give BCG if there is a suspicion for MDR and you cannot separate them. So if there is a suspicion for MDR, but you can find another placement for the baby until the mom is on effective treatment, then that's the way to go. But if you cannot separate them before that, then basically do BCG. And I think you can get it through the CTC, if I'm not mistaken. So it's not like the hospitals don't have it. Usually the hospitals don't have it, or the clinics don't have it, but can get it. I think it's through the CDC, but I can do a little bit of finding out the exact details if somebody wants to know.
And I think it's important to just reiterate that the BCG is not going to necessarily prevent them from infection or treat them, but it may help to avoid disseminated, more severe forms of TB if the baby does acquire tuberculosis.
Exactly. So those kids that get BCG are not completely out of the woods, but at least we offer them the protection from severe illness when they're a baby.
And also to remind the families that the skin test will no longer be an accurate test in that young child because of its cross-reactivity with BCG vaccine.
Well, it will not be after, if they get BCG, then we cannot use TST to rule out infection on the baby. But if a baby gets BCG after, we say about maybe 4 or 5 years, then you can interpret the TST regardless of BCG vaccination.
Great. So I'm going to ask one more question, kind of combining a few that I see here. There seem to be a few more questions about window period prophylaxis. Could you maybe summarize again the appropriateness of window prophylaxis, particularly patients with HIV, and when you would be willing to use it, what situations you would use it in?
Okay, so window prophylaxis is, so basically you have to rule out disease first of all. So those patients that you're considering window prophylaxis are the high-risk patients, either because of age, so the very young, and then patients that have conditions that predispose them to develop TB disease. So HIV, but also like all of the list of medical conditions, immunosuppressant therapies, and certain kinds of cancer, diabetes, all of those. So the ones that have the very severe immunosuppressive conditions, so HIV, the transplant patients and the ones of tumor necrosis alpha antagonists, those three, it is thought that the results of the IGRA or the TST are a little bit questionable. In HIV, I say depending on their CD4 count. If their CD4 count is really good and they've been on therapy for a long time, you can interpret the TST or the IGRA. But if they are immunosuppressed, then you don't know if the IGRA or the TST is negative because of the immunosuppression. So in those, you don't really even do window prophylaxis. You basically you treat them anyway. You assume that they potentially got infected, and because you cannot rule it out, you treat them for 9 months or 6 months or 4 months of rifampin, depending on their age. But you don't repeat the TST. The other conditions, the less than 5 years of age, and the other conditions that increase the risk but are not the severe immunosuppression, those you do window prophylaxis, and it's after you rule out disease. So those patients need to have TSTs and X-rays and full evaluations before you put them on INH as window prophylaxis, and then they get a repeat, either IGRA or TST, 8 to 10 weeks after their last exposure to the case. And then if that test is negative, then you can stop the INH or the rifampin. Is that clear?
Thank you so much. That was an excellent summary of that. And again, for a fabulous presentation, just so clear, and really appreciate all of those extra points and addressing these questions. And I'll just remind you that Anna also can be reached through our MTD hotline, 1-800, I don't even remember the hotline number, 4TD-INFO. So if you have questions regarding specific investigations or pediatric patients, you can always reach Anna or one of her colleagues through that line through our region, and I believe the other regions may also have a pediatric consultant, but I know Anna would be very glad to help you with specific questions in the future. So with that, thank you all for attending.